All right, we can get started. Good afternoon, everyone, and welcome to today's webinar, Establishing an Environmental Exposure Registry, Operational and Legal Lessons from the Flint Registry, brought to you by the Network for Public Health Law. I'm Sadia Mohammed, the Marketing and Communications Associate at the Network's National Office, and I will be your host for today's webinar. We strongly encourage attendee participation, so feel free to submit questions at any time during this webinar by using the Q&A button on the bottom of your screen. Your moderator for today's webinar is Peter D. Jacobson, who is co-director of the network's Mid-States Region Office and Professor Emeritus of Health, Law, and Policy and Director at the Center for Law, Ethics, and Health at the University of Michigan School of Public Health. Peter will be leading us through the rest of today's webinar. So Peter, over to you.
Great, thanks a lot, Sadia. It's my pleasure today to introduce our panelists and presenters. But first, I just want to comment on what a wonderful collaboration this has been between the network and the Flint Registry and our partners at Michigan State University, and with Mona, Hannah, and Tisha, who's the PI on the overall project. I hope you'll find this webinar challenging and interesting, and please, questions in either the chat or the Q&A. And thank you. Let me introduce our panelists now. Nicole Jones from MSU, Felicia Estrog also from MSU, and then my network colleagues, Denise Chrysler, who's the director of the Mid-States region, and Colleen Healy-Bufides, deputy director of the Mid-States region. And Nicole, all yours. So we'll have, the order will be Nicole, Felicia, then Nicole, then Denise, Colleen, and then everyone, and questions and answers. Nicole, all yours. Thank you.
Great. So good afternoon, and yes, welcome to our presentation discussing the establishment of the Flint Registry, which is an environmental exposure registry created in response to a lead in drinking water crisis. And today we'll share both operational and legal lessons. The Flint Registry was established with the help of many partnerships, relying upon expertise from scientists, physicians, community providers, and community members. And as Peter says, the work today highlights one of those collaborations, a 5-year partnership between our two organizations. And today, as we focus in on the legal issues that we worked through in establishing the registry, I hope you can see the value of this partnership and the impact this partnership has had on extending the work of the Flint Registry. So today we'll present an overview of the implementation of Flint Registry, including operational considerations and challenges, relevant legal issues, as well as a legal handbook to guide other communities wishing to establish a non-governmental public health registry. So we'll start with a background on the Flint water crisis and Flint Registry, give you an overview of our operations and some of the legal issues, summarize our lessons learned, and finally finish up with our conclusions. So we can go to the next slide, please. I'll begin with a brief introduction to the Flint water crisis. Next slide, please. In April of 2014, the city of Flint was under a state-appointed emergency manager. And in a cost-cutting measure, the water source for the 99,000 residents of the city of Flint was switched from pre-treated water received by the Detroit Water and Sewerage Company to locally treated water from the Flint River. After the water switch, residents began complaining of poor water quality, odor, taste, smell, discoloration. However, their complaints were largely dismissed. Unfortunately, the local water treatment protocol did not include adequate corrosion control, and as a result, lead leached from the water supply lines into resident drinking water. Lead is a well-known neurotoxin and a serious health hazard, especially for children, and can lead to lifelong health harms, including cognitive and behavioral delays and challenges. Documented impacts of the Flint water crisis included an increase in water lead levels, as well as elevated blood lead levels in residents, and an outbreak of Legionella. In this photo, you can see discolored tap water from a Flint hospital during the time of the water switch to the Flint River. Next slide, please. So we'll walk you through now the timeline of establishing the Flint Registry. So Following the demonstration of an increase in blood lead levels in Flint children in October of 2015, the water was switched back to Detroit Water, but the damage to the pipes was permanent and a federal emergency was officially declared in January of 2016. The Flint Registry was first envisioned by community members and formally requested in January 2016 and submitted as a recommendation to the Emergency Operations Center. And the reason behind the request was the Flint water crisis was a widespread event with potential for a long-term health and development consequences, and there were available interventions that could mitigate the impact. Therefore, a need existed to create a registry to identify those who were exposed, to connect them to resources, and to understand the long-term impact of the crisis. In December of 2016, Congress officially passed the WIN Act. And included in the WIN Act were federal funds for the creation of the Flint Registry. These funds were appropriated to the CDC, which established a notice of funding opportunity. MSU applied for and received grant funding from the CDC in August of 2017. The first year, we really spent that year working on community engagement activities, hiring and training registry staff, creating IT and other infrastructure, and really building the registry. We officially launched in December of 2018 with our staff ready to assess eligibility of those who signed up, to obtain individual consent to participate, to administer surveys, and to make referrals to over 30 different services and programs. In 2021, we completed our first 4 years of funding from the CDC, our original grant, and received a 1-year supplemental funding. In 2022, we're completing that 1-year supplemental funding and have applied for additional funding to continue the long-term work of supporting recovery from the Flint water crisis. So now Felicia will talk more about our registry operations.
Thanks, Nicole. In the initial phases, as Peter mentioned, our PI, Dr. Mona Hannah Atisha, and Nicole created the registry patterned after our friends at the World Trade Center Health Registry. And it was patterned on 2 foundational pillars. Those 2 pillars were 1, the 6 public health goals set forth by the CDC in the initial grant funding, and 2, the idea that this registry, since it was conceived of by the community, would therefore also be continually informed by the community. Next slide. Here you can see the 6 public health goals as set forth by the CDC. These goals, as well as the eligibility criteria of serving those who lived, worked, went to school, or attended daycare at a location that was served by the Flint water system during the switch, form the scientific foundation of the registry. The second objective is for the registry to be community-driven and informed organization. The Flint water crisis is a result of an environmental injustice rooted in the dismissal of a predominantly poor and minority population. A lack of listening and consideration of community voice led to this crisis. Next slide. Here we have a list of just a few of our community voice and informed areas. Some of these, such as the parent partners, our community advisory group, as well as our registry ambassadors, continue to serve as a view and community advocate for the Flint Registry. And then we also use local presentations, focus events, and continually use this to inform how the registry grows and is administered. This response is driven, informed, and partnered with a community that is essential to Flint's recovery. Based on these principles, the Flint Registry is designed, built, and implemented to include and elevate these shown community voices. Next slide. So in creating of the registry, there were a number of operational barriers and hurdles that we first had to overcome. At its very base, a registry is the engagement of individuals and a collection of their stories. So in order to do that in a timely fashion, we borrowed and currently live the phrase, building the plane while it's flying. To create a study, we had to find and enroll participants. So we engaged community partners to spearhead our broad outreach campaign and market the program via traditional and social media ranging from billboards, bus wraps, citywide mailers, promoted social media presence, and unabashedly using Dr. Mona's social media following. We also created a community-informed eligibility, consent, and enrollment survey that could be completed in a number of ways. Based off of community feedback, we wanted to make sure that the survey could be completed via paper, phone, online, and before the pandemic in person. In order to be as accessible as possible, email or a phone number was not required. All that we need is a name and a date of birth. To start, before the registries kickoff in December of 2018, we started with a pre-enrollment process to officially gather individuals before the launch of the survey. This drummed up interest and served as a pilot on how to manage individual records. From there, the basis of our service is via referrals that are generated based on the initial eligibility criteria included in the survey. We collaborate with existing community programs and platforms to refer individuals to local and state services while maintaining and safeguarding all their personal data. These referrals fall within 4 domains, which will be discussed later, of lead elimination, health, nutrition, and child development. Once a participant has been referred, we then track the referral status via a community referral platform. So all of this requires a significant technological lift. Currently, we use 2 systems, RedCap to administer the survey and manage the database for enrollment information, as well as Epic, the electronic medical record system used by our partner, Hurley Medical Center, which allows us to manage each participant's information and engagement. For those of you tech nerds who are interested in how we got 2 systems that are nothing alike to work together, we're in the process of publishing an article about that quite impressive process, which will be soon available through the Flint Registry. And finally, all of this, most importantly, requires people and procedures. We are blessed to be part of Michigan State University, but are also limited by that large bureaucratic research institution. We are located in a Michigan State's building of College of Human Medicine's Division of Public Health in Flint, and that provides us operational basis for space, phones, computer, human resources, purchasing, and the grants management, again, associated with the large research institution. With all of that said, we are proud of this plane that we continue to build. We continue reminded of why we do this work, to serve the residents, especially the children of Flint who endured dangerous water followed by a pandemic. The basis of the registry has shown to be fairly universal across now multiple public health crises. And we continue to build on the registry's success as we look towards the next 5 years with our community. Those next 5 years are thus informed by our first 5 years. And I'm going to hand it back to Nicole to talk about the impact of the registry. Next slide.
Great, thanks, Felicia. Yeah, so we can talk, thanks for sharing about our operations, and we'll move on to our impact in the next slide, please. So we set a goal to enroll 20,000 individuals in the registry, or about 20% of the individuals who were exposed during the time of the water switch. And to date, we have enrolled over 19,600, so very close to our first goal, individuals, and made over 25,000 referrals to services. Taking a look at who's in the registry, about 2/3 of the enrollees are adults and about 1/3 are children. Those are children that are enrolled when adults complete surveys about their children. And the majority of individuals who enroll in the Flint Registry are still living in the Flint area at the time of enrollment. So, a small percentage are still in Genesee County or still in the state, and a very small percentage of individuals who are no longer living in the state of Michigan and will enroll in the Flint Registry. Next slide, please. The key outcomes that we expect to achieve are increased use of preventative services, better health and fewer developmental delays among participants, an understanding of how Flint families are doing overall and in comparison to other communities, and to identify gaps in resources and to advocate for and implement additional resources. Next slide, please. So about 2/3 of individuals in the Flint Registry receive at least one referral. Enrollees may not receive a referral if they decline consent for referrals, if they're not eligible for services that we're referring to, or if they are already enrolled in the services we're referring to. As Felicia mentioned, referrals are made across 4 main domains: lead elimination, which includes programs like the Lead Safe Home Program and the Pipe Replacement Program, which is an ongoing program administered by the City of Flint to replace lead service lines funded through a legal settlement. Health programs support things like access to healthcare, access to a medical home, referrals to mental health services, to dental care, and include programs across the lifespan from children to seniors. Nutrition programs support food needs and include programs that are more targeted for longer-term support, such as WIC or the Federal Supplemental Nutrition Program, along with emergency food assistance programs. And finally, child development programs focus on early education and literacy support. Next slide, please. So here I summarize the most common needs that have been identified across these 4 domains, beginning with adults on the left side of the slide. The most common referral that we've made for adults is the pipe replacement program that I mentioned. The second most common referral that we've made for adults is to a mental health provider, shown in light blue. We make this referral when an adult indicates that they would like a referral to a mental health provider, or when they score high in one of the mental health screeners in the survey they complete at enrollment. The other 3 most common referrals that we make for adults are to food assistance programs. For children, on the right hand, shown on the right hand side of the slide, the most common referral we make is to the Neurodevelopmental Center of Excellence, or NCE. The NCE is a place where parents can take children for a complete neuropsychological assessment. We will make a referral here if a parent requests a referral, or if a child scores with a significantly elevated score on one of the behavioral assessment screening tools in the survey. The next most common referral we make for children is to the Lead Safe Home Program, which is a primary prevention program designed to screen homes and eliminate sources of lead. Other common referrals for children are to programs to assist with access to health insurance, to the Nurse Case Management Program for children with elevated blood lead levels, and to child dental programs. Next slide, please. Now to just briefly take a look at some of the health concerns of our enrollees. When we asked adults to report on their overall physical health and mental health, 37% of adults rated their physical health as poor or fair, and 34% of adults rated their mental health as fair or poor. Next slide, please. When we ask adults about the amount of stress or pressure they experience on a daily basis, Flint Registry adults on average reported higher levels of daily stressors as compared to national norms. The mean perceived stress score for Flint Registry participants are indicated in dark blue, and national norms are indicated in light blue. And you can see this trend is most significant for the youngest adults in the Flint Registry. Next slide, please. We also asked adults about their access to nutrition. When we ask adults, within the past 12 months, were you worried that your food would run out before you got money to buy more? We saw a high level of food insecurity, with 43% of adults responding yes. This is also reflected in the referral data that I shared, where one of the top referrals that we make for adults are to food assistance programs. When we ask adults about access to fresh fruits and vegetables in their neighborhood, 26% of adults indicated that they disagreed or strongly disagreed that they had access to a large selection of fresh fruits and vegetables in their neighborhood. Next slide, please. We also asked adults with children in the registry to rate their overall child's physical and mental health. And 10% of adults rated their child's physical health as fair or poor, and a slightly higher 16% of adults rated their child's mental health as fair or poor. Next slide, please. We also asked adults with children in the registry to describe their financial stress. 46% of our enrollees reported that it is very often or somewhat often very hard for them to cover the basics like food and housing. And please keep in mind that most of these data were collected pre-COVID. When we asked about food affordability, 1/3 of our families could always afford to eat good, nutritious meals. Half of our families could always afford enough to eat, but not always the kind of foods that they should eat. And the remainder of our families sometimes or often could not afford enough to eat. Next slide, please. This slide presents a summary of some of the child behavioral and mental health screening data collected on the survey. Specifically, this slide summarizes data from one of our screening tools, the Behavioral Assessment System for Children. The different colored bars represent age and gender groupings of children, and the height of the bars in this graph represent the percentage of children in each category that scored in the at-risk or clinically significant range across 4 main domains: externalizing problems, internalizing problems, behavioral symptoms, and adaptive skills. The dark line indicates the percentage of children that should score in the at-risk or clinically significant range. And as you can see from the graph, across almost all age and gender groups, Flint Registry children were more likely to score in the at-risk or clinically significant ranges. Children who scored in this range were then referred to the NCE for a complete diagnostic assessment. Almost 50% of children who enrolled in the Flint Registry scored in an elevated range on at least one screening tool, and therefore were referred to the NCE. So now that you understand more about the operations and the impact of the Flint Registry, Denise will present information about some of the legal issues we faced when establishing the Flint Registry.
Thank you, Nicole. Hello, everybody. We knew what we wanted to do, and Felicia talked about the heavy technological lift to do it, and so I'll talk about the heavy legal lift. And then, of course, Nicole talked about a lot of the results. In order to establish a registry and populate it, of course, you need data. You need identifiable data from various sources. Here, there was the state health department that had a lot of data that would be helpful in carrying out the purpose of this project, data from healthcare providers. We had hoped to obtain data from schools and failed, et cetera. So as soon as you're talking about obtaining identifiable data, you're talking about law. And so you start with the questions of what data do you want, for what purpose, who holds the data, and then identifying the relevant laws to navigate those and hopefully find a way to obtain the data you need. Next slide, please. Public health registries are a well-known tool that health departments use for systematic collection of data. They use it for surveillance, for monitoring outcomes, here for referrals, for assessment, and especially of interventions such as the registry and other public health purposes. Whenever you have the collection of data or surveys, you have to ask yourself, is this public health practice or research? If it's research, in addition to the typical public health laws and other confidentiality statutes, you will have possibly the common rule or other laws that apply with regard to research, and then satisfying the requirements of an institutional review board. I believe from Nicole's description, this was pretty clearly a classic public health activity to monitor and assist the people within Flint to get them the services they need, to assess how well those services worked and how well the tool itself was working to serve the residents of Flint. Next slide, please. Public health agencies have the authority to establish and operate a public health registry. Often information is required by law to be provided, identifiable information, without an individual's consent. And the HIPAA public health exception would allow this kind of reporting from health plans such as Medicaid and healthcare providers, which are a major source of information in state data systems that serve the public's health. Next slide, please. However, this was a registry established by a university. The Water Infrastructure Improvements Act for the nation, the WIN Act, is part of the Public Health Service Act. It directed the Secretary of HHS to establish a Flint-led exposure registry, and it could do this either directly or through a contract or grant with another entity. And in this case, CDC selected Michigan State University, a major academic research institute, and also an institute with long-established relationships in the Flint community. At times, universities can offer advantages over state or local health departments. They may have extensive data support services, analysis services, national experts in areas you need. And as I mentioned here, long established relationships, and additionally, the trust of the public. For this particular registry, Michigan State University was not involved at all in the issues of the water system that caused the lead to leach into the water supply. The addressing those issues, that was done by federal, state, and local agencies. There was a public health authority designation granted by the CDC that was very important, that would facilitate the flow of data so that Michigan State University was treated just like a state or local or other public health, governmental public health agency. While very important, it didn't solve all the issues. As I mentioned, there's no inherent authority for a university to collect identifiable data. Even for public health purposes, the university would either need consent, be authorized by law, or the public health authority, as I said, facilitated that. But also there's a lot of other laws that apply. Every database that we were concerned with had a law that applied to it that had to be satisfied. And additionally, disclosing information is within the discretion. Here, a lot of data needed from the state health department. Next slide, please. In data collection, there were two phases, recruitment and outcomes. I'm going to, I think I've set it up, send in the chat the different databases which ended up supplying information from the state health department. There were many more databases than this initially identified, but there were either legal challenges or it was found that the other databases were not necessary or duplicated information that was obtained. And then of course, always the variation, the patchwork of laws, the federal state laws that you need to comply with. In any data sharing, you have to look at what data do you want, from whom, for what purpose. And this has a link to the network's checklist of factual information needed to address proposed data collection. Next slide, please. For recruitment, consent was very much a part of this project, but when you're recruiting individuals, it's pretty difficult to have consent. And so contact information was needed to target those individuals who most likely qualified for the registry and could be served by it. We had some sources of data which were very helpful, like the Michigan Department of State provided. The registry was able to demonstrate they met all the laws that apply to the list of driver's license information and information about individuals with state issued IDs. There were commercial lists used to identify individuals, but those are often not up to date. A very important source of data would have been the local school districts. While we believed we had demonstrated for one school district that both law and policy allowed them to share data, we were not successful there. And then the other school district had policies in place that meant it was difficult to or impossible to obtain data from them. To obtain data for contact purposes and then outcome purposes, the registry did enter into a data use agreement with the state of Michigan. One particular concern where data is provided pursuant to a public health authority. For example, CDC no longer funded the Flint Registry. Would that public health authority be withdrawn? And then what would happen to the data? Those issues are addressed in the data use agreement. Next slide, please. And then we have the outcomes data. I refer you again to the chat box that talks about different outcomes data that was obtained. It is possible to obtain consent. That doesn't mean that was easy, as Colleen will be speaking about right after me. As we mentioned, every data set has different laws, including what needs to be satisfied for purposes of consent. And so, as I mentioned, there was a two-prong approach, an executed DUA to obtain data under public health authority, and then consent from registry participants to obtain data. Next slide, please. And this, we turn over to Colleen.
Great, thank you, Denise. So I wanted to spend a few minutes talking about the consent process. The registry requested participant consent for several purposes, including consent to participate in the registry, consent to allow third parties such as MDHHS to share the individual's health information with the registry, and consent to allow the registry to share information with service providers to make referrals. Each of these different elements of the consent process involve different legal considerations, but have a number of ethical considerations in common. So both legally and ethically, consent must be competent, voluntary, informed, and understood. And respect for autonomy and confidentiality are other key ethical considerations in developing a consent process. With respect to the legal issues, we had to evaluate different laws for each type of consent needed. So for example, with regard to participating in the registry, we evaluated federal research regulations, HIPAA, the Michigan Public Health Code, to identify any potentially relevant consent provisions. Ultimately, we determined that none of these laws applied to obtaining consent to participate in the registry. For instance, we concluded that the federal research regulations did not apply because the primary purpose of the registry's data collection was for public health practice rather than research. We also did not identify any laws applicable to obtaining consent to disclose individual health information for the purpose of making referrals. For example, we looked at HIPAA, but HIPAA doesn't apply to the registry because the registry is not a HIPAA covered entity. In contrast, we identified multiple laws with varying legal consent requirements applicable to obtaining individual health information from MDHHS, as Denise just mentioned. Although there were some types of data where the registry could have obtained the data without consent, based solely on the CDC's grant of public health authority, the registry ultimately requested consent to obtain most of the data that it requested from MDHHS. This decision to request consent, even where it was not required, reflected a broader stress on assuring transparency and building trust in the community. In addition, requesting this consent gave the registry an opportunity to seek broader information than may have been permissible under the narrow statutory provisions covering non-consented data disclosures, such as through public health exceptions. Next slide, please. So the consent form needed to address all three elements of consent described on the previous slides. So consent to consent for MDHHS to share data with the registry, and consent for the registry to disclose data to service providers. The primary legal considerations had to do with obtaining data from MDHHS. So for example, the registry had to comply with HIPAA authorization requirements to obtain Medicaid data from the state. We also did some research looking at proxy consent issues, determining how to obtain valid consent for minor children being cared for by guardians or foster families, as well as incapacitated adults. Ultimately, the registry has found that among the participants, 84% of adult enrollees have agreed to share information with referral agencies, and 71% of adult enrollees agreed to share data from MDHHS with the Flint Registry. And they've also found that 89% of adult enrollees agreed to be contacted by the registry about possible future research. Next slide, please. We considered a few other relevant laws as well, or potentially relevant laws, which are laws that any public health registry would want to consider when using federal funding. So first is the Federal Privacy Act, which regulates federal agencies' collection and use of data. The Privacy Act applies primarily to federal agencies, but we reviewed the act to see whether the Flint Registry's funding arrangement with the CDC meant that the act applied to the registry. Ultimately, we concluded it did not, based on the enabling legislation for the registry, the terms and conditions of the grant award, and case law. We also looked at federal laws that provide additional protection to identifiable information through a federal certificate of confidentiality or assurance of confidentiality. But these only apply to research and CDC programs and contractors respectively, so the registry did not qualify for either protection. Finally, we looked at electronic transaction laws to make sure that electronic enrollment and consent processes would be valid. To comply with these laws, one of the primary elements the registry implemented was into electronic transaction was to provide participants with a printed or emailed copy of everything that they signed. Next slide, please. I'll turn it over to Felicia now.
Colleen. So with the registry, again, of collecting the data and then using that to collect their stories and then refer to services to help mitigate the effects of the lead water crisis. With creating a public health registry, there are a number of operational considerations, some of our successes and some of the things that we would do differently if given the chance. Again, one of the foundational aspects of the registry was a community engagement strategy. We continue to base all of our activities on this, but with that creates sometimes some challenges in the request to maximize flexibility, sometimes in creating a forum for community feedback that does extend the time in which operational procedures can be put in place. But then also with some of the feedback, for examples, I mentioned before this, to complete the survey, we do not require an email or phone number to track. So that meant technologically in gathering information and utilizing that as an identifier, we had to come up with other ways. And also the community requested that when being paid for completing their survey and appreciation, they wanted that in cash or check as opposed to a gift card. So in utilizing Michigan State's processes to provide that check, that operationally took a little bit more than if we were to issue gift cards. But in listening to our community, we found that to be the most important because, as Colleen and Nicole have also mentioned, building that community trust was a foremost important part of the registry. And building that trust, that also means protecting that data once we were able to collect it. It also means that we need to be very aware of how our presence in the community and our partnerships with other organizations are viewed. With pre-enrollment and starting that community trust, gathering information about potential enrollees and participants as soon as possible was foremost important in gathering our participants. Our goal is 20,000, as Nicole mentioned. We are very, very close at almost 19,700. But without especially that information that Denise and Colleen mentioned from the school systems and others, having community trust and broad outreach was important to pre-enroll and eventually enroll. Some of the areas that we did find that were the considerations and challenges, especially in the IT infrastructure. I'll discuss this in a little bit when we go into recommendations, but having a two-system approach, neither of which were built as consumer or customer relationship systems to allow for mass communications has proven a challenge. If we could reformat our systems with that type of communication as a priority, I think that we would. Our multi-layered consent process, which we've discussed in depth, also then took technological implementation challenges. By the time that we had an accurate consent that was approved by MDHHS and Medicaid, our system and survey had already been launched. And the amount of time to implement separate screens, signature requirements, and official consent from participants after they had already consented to join the registry, consented to have their information sent for referrals, and possibly consented to being contacted by other studies in the Flint area. We do think that we missed some participants in their consent for matching their information to MDHHS databases and Medicaid information, as they had already completed their baseline survey and their follow-up survey before a technological opportunity for them to consent was possible. We had to send those consents in the mail. As I'm sure many of you would realize, getting consents back from the mail has not necessarily proven to be universal. And then finally, the referral process, which is the basis of our mitigation strategy for lead exposure within the registry. We refer to services across the city of Flint and Genesee County, but we are not the provider of those services. And so having to work with the community and also to help our participants navigate the healthcare and social systems in the county, while oftentimes who are also navigating a global pandemic, has created its own challenge. But with those, back to the legal challenges. Next slide to Colleen.
Thanks, Felicia. So there is significant overlap between the operational challenges and legal challenges because they contributed to each other often, as Felicia was explaining. But a few key issues affecting legal aspects of the registry are listed here. So one is community distrust. Distrust was part of the reason for adopting such a robust and transparent consent process, even in some of the instances where consent was not required. Interagency cooperation was also a challenge sometimes, not due to a lack of cooperation, but just because it requires a lot of time. In particular, coming to a shared understanding of the law with MDHHS and developing data use agreements required a lot of back and forth. A third challenge was obtaining lists of potential enrollees, since this required obtaining data without consent. As we've mentioned, ultimately the registry was not able to obtain students' names from schools, even though schools were could have been such an important avenue for contacting young families with vulnerable kids. And then finally, there were a few distinctly legal barriers. Broadly speaking, one of the key barriers is just that federal and state privacy laws are fragmented, confusing, and sometimes difficult to interpret and apply. There are many laws at play, and they all need to be considered and harmonized in developing data sharing and consent processes. And we can go to the next slide for our recommendations.
So in looking forward of creating another public health registry, we have a few recommendations for the practice, which first is communications, specifically broad outreach, pre-enrollment, which we've discussed, and referral communications. These communications are both internal and external, with partners as well as participants and community members about what the registry is, what the registry can do, and how the registry affects the community and individuals. Second, technology. We utilized an off-the-shelf technology. We utilized 2 off-the-shelf technologies. We ended up customizing as much as possible, but both, again, our partners with the World Trade Center Health Registry would agree that if you have the time and the money upfront, a custom build may serve a future registry more robustly than using off-the-shelf technology. While we use REDCap to administer our surveys and Epic to keep track of our participants, in looking at the next stage of cohort maintenance and continuing to communicate with our participants, we've had to be creative in our mass communication opportunities, as well as creating individual and participant records to keep track of how we engage individually. And finally, using marketing to explain the processes and limitations, including that information about data collection, why we need the information, what information we're going to use, how we're going to use it, and how we will and will not share that information was and is very important to maintaining that community trust, as well as the integrity of the registry as we move forward with that longitudinal study. Colleen.
Great. So one of our legal recommendations is simply to update and improve data laws to facilitate public health data sharing. For example, one change that would be helpful is if more data laws established more flexible consent processes, particularly when the data is being disclosed for public health purposes. For legal provisions that are difficult to interpret and harmonize, it would be helpful to have more agency guidance so that data holders feel more comfortable disclosing information for public health reasons. Related to that, with respect to FERPA, which is the law protecting the privacy of student records, we suggest that agency guidance would be especially helpful to encourage schools to disclose school data for public health purposes, especially where kids are at heightened risk and the data is minimal, such as including only names and contact information. And finally, we'd suggest that a health department's default policy should be to disclose records to a public health authority for public health purposes unless there is a compelling reason not to. This default in favor of disclosure might facilitate greater sharing of public health data and might substantially simplify the process, allowing for more and more robust public health programs and collaboration. Next slide, please. So I'd like to point you all to our new legal handbook for establishing a public health registry, available at the link included here. This covers much of what we discussed today and includes the data use agreements and consent forms developed by the registry for reference by other communities. Next slide. So in conclusion, it's through long-term work, advocacy, and community partnerships that the Flint Registry aims to provide infrastructure to support the overall health and development of Flint families and to provide community-level data to understand ongoing programming needs. We hope that the challenges and successes we've discussed today will be helpful to others interested in starting public health registries. And we're looking forward to discussing with you in just a few minutes. Next slide. We'd like to thank our colleagues at the Network for Public Health Law and the Flint Registry for their contributions to this presentation and to the legal handbook, and to the Flint Registry, Flint Community, and the Flint Community Partners. Next slide. We've shared funding information here, and then on the last slide is our contact information for speakers, and we'd love to hear your thoughts. So I'll turn it over to Peter.
Great. Thank you. Thanks all for an excellent presentation, very thorough and with a lot of key information for our audience. To the audience, our presenters made this seem somewhat easy. Let me assure you it's not, but I think if you're interested in developing a similar type of public health registry, the handbook will save you a lot of time. The authors have spent a great amount of time trying to make it very user-friendly, and it will save you an enormous amount of time. We have two very interesting questions to start off from our audience. The first is, has anyone considered the use of blockchain technology to create such a directory? And the second part is, as long as participants knowingly consent with evidence of a contract to self-report data, is there any reason why a private registry can't be created to monitor for a group of concerned citizens, such as over suspected environmental contamination that might otherwise not be recognized by public health? So a twofold question: is blockchain technology something that's feasible, and could a private registry be developed? I don't know the answer to either one, so I turn it over to anyone who wants to try to answer it.
This is Denise. I can try to speak to blockchain, but if Felicia or Nicole have more advanced knowledge than I do, please correct me or add. And I don't think we have a way for the attendee to speak up, because that would be very good to have a discussion, and I would like to have a discussion offline. If I understand blockchain, I think the attendee is talking about the kind of technology that Massachusetts used a couple of years ago to link individual records without revealing identifiers, and then providing that data in aggregate form in a way that it could not be de-encrypted and individuals identified. If I have that correct, and I'm not sure if you're talking about for directory purposes or outcome purposes, but in addition to, a lot of population health purposes of this registry, it also was involving relationships with individuals and healthcare providing healthcare through Hurley, which is part of the Michigan State Health System. But I know Nicole and Felicia could probably speak better than me about the relationships and the importance of having contact with individuals.
Yeah, Denise, that was a great answer to the question. And what I would add to the response is when we're looking at how broadly we were able to connect with individuals and recruit them into the registry and therefore distribute the intervention across as many impacted individuals as possible, outreach was very important. We actually track when people enroll, how they heard about the Flint Registry. And about 50% of individuals who came into the registry heard about it through sort of a traditional academic recruitment method, such as phone calls or mailings or media. And about 50% of enrollees heard about it through a community organization or community partner or word of mouth. So the relationships in building relationships and really engaging people was really important piece of getting them to enroll in the registry.
And I also think with the registry, it wasn't just collecting data, but it was also matching data to see outcomes. One of the public health goals set by the CDC was to show an improvement in health outcomes. And so to do that, we had to match that information and also to share with referral partners. So while blockchain technology could possibly be used in keeping the data, we still had to go through a significant amount of consent and legal steps in order to then share information with our referral partners to make sure that there were those interventions available.
And there were a couple follow-up questions about where are the data kept and for how long?
Nicole and Felicia on that.
So we keep the data currently within Michigan State's technology system. Again, this is one of the benefits of having a research institution that also has an IRB. While this is not a research study, we do still have those resources. And then we are currently working with other friends at the University of Michigan with a virtual data enclave. And so that will be a secure area with which to keep our data, curate the data, and then eventually be able to share non-identified data with other research partners for long-term study.
Great. So our next question is, can you please talk in more detail about school district reservations to share data? This seems like an important set of data given lead's toxicity. I agree.
That's me, and I agree fully. First thing I do when I'm looking at getting school district data is first review the exceptions to FERPA. I think I know them pretty well that allow disclosure without consent. And then I look at school policies. So the first offhand, both school districts we worked with said, no way, FERPA won't allow it. Then I pointed out the policy to one that allowed the disclosure of contact information. And then they advised us, well, you're right, but technologically, you can, first, you can opt out under FERPA. If you've opted out on having your contact information shared, we can't share it. And technologically, we have no database or way to know who's opted out. The other school district had adopted a policy that prohibited even sharing contact information. I always think about the importance of the school district as a partner. This meets everybody's mission of making sure students are in school and able to learn and be successful, and building those partnerships is a way to be able, if school districts and having the correct agreements in place of public health or a private registry, helping schools to achieve their mission. And in that way, there may be options.
Yeah, but let me push back on that on behalf of the questioner. Why are the schools not, why are they putting up a smoke screen? It's clearly a legal smoke screen. Why?
Well, these two school districts replied on the advice of their attorney, and their attorney, even though Dr. Monahan Atisha submitted 2 letters, one explaining why this was directory information they could provide, and another to show that this was a health emergency where the data was needed to mitigate the effects of lead. Both of those strategies were used. And I can't say whether it's a smoke screen or not.
That's like taking,
because that implies
when you're under subpoena.
I know something that I don't know.
Yeah, well, as I was saying, talking over you, it's like taking the Fifth Amendment when you're under subpoena.
Okay.
But another important question from our audience is what role, if any, has the local health department played in the project?
So I'll take that question. We actually had a partnership with Genesee County Health Department with regards to specifically the kids that were 0 to 6 years old during the time of the water switch. So Genesee County Health Department took the lead in making sure that those kids, because of some Healthy Start programming expansion they had, were connected to services and resources. So we essentially did some work on behalf of them, supporting that project to make sure that we were spending extra resources and extra time locating those kids and making sure that they got connected to services and resources. And then we're also part of a collaborative across the county with other agencies that Genesee County Health Department supported, really targeting those kids that were 0 to 6, making sure that they were getting connected to services and resources. And then, Felicia, do you want to talk about the funding question that popped up?
I will. I'm going to add a little bit to Nicole's part. So in addition to working with the county health department, we also continue to partner with the city of Flint itself and their public health door-to-door initiatives in both awareness of the registry as well as in the oversight and community input about how the registry operates. And then for funding, as Nicole mentioned, we have submitted the application for the next 5 years. It was a sole source application. Michigan State University was the only eligible applicants. We feel very good about the continued funding of the registry. It has moved from a 4-year plus a supplemental standalone funding to being tied to the annual appropriations through the Centers for Disease Control and Prevention appropriations through Congress. So with that, that gives it the establishment and foundation for long-term funding.
Great. So we only have a couple minutes. I have lots of questions, but as I said before, I think you guys made it all look easy. But aside from using the handbook, what advice would you give to someone who wants to start a registry based on both your experience of doing it now and then what you think you've learned from it?
I think that collaborations and partnerships are so important. So as highlighted today, really getting advice from lots of different people. And also I see our friends from the World Trade Center Health Registry are on today, thanking them also for just really being there to kind of give us advice. But the first source of advice is really our community members, the ones that really direct us and guide us and tell us what is needed.
Great. Anybody else? Let me ask a slightly different question for probably the last one. The 20% figure can be construed as both a high number to achieve, but a low number of all possible participants. If you were able to get this percentage up to 50%, let's say, are there enough services available to meet the demand?
That's a great question. First of all, again, we set the goal based on our advisors at the World Trade Center Health Registry and what they were able to accomplish with their work. There are always gaps in services, and especially mental health services for families and for youth. So even there's never enough support in that area for families, and services are available, but there's always a wait. So even with the number of services that we have available now, I think we could use additional support.
So our last question is an important one also. Will the registry use its trusting relationships to encourage Flint residents to use the renovated public drinking water system? Not to put you on the spot or anything, but
we really, again, just kind of listen to the community voice and let them lead us, as opposed to, I mean, we do, share information, but I I understand that this drinking water crisis is more about just exposure to lead. It's the trauma that our families are facing. So of course we will share information with individuals, but encourage them to make the best decision for what they feel comfortable for their families.
Great. Well, I'm afraid we're out of time. Thanks to our presenters for an excellent webinar and to our audience for an excellent set of questions. And if anyone has other questions, please feel free to get in touch with any one of us. We're happy to continue the discussion, and I'm sure we would all be amenable to talking to you in greater detail if you're interested in starting a public health registry.